we will come now to our next guideline, which is a first guideline for the management of cardiovascular disease and chronic kidney disease, developed together between cardiology and nephrology, and Dr. Herrington and Dr. Damman will present this to us.
So today, kidneys and urine are in the spotlight in Munich, and deservedly so. We thank the ESC for the opportunity to speak to you all about kidneys. Kevin and I are honoured on behalf of the task force, the ESC, but also the European Renal Association, to present this brand new guideline. It's unique in its depth and insights into kidney disease within the field of cardiology, and a uniquely close collaboration between nephrology and cardiology. These are our declarations of interest. So why now? Because I think many of you will have known for over 2 decades that as glomerular filtration rates, GFR, falls below 60, there's an increased risk of cardiovascular disease. And that in the presence of urinary albumin, those risks are shifted up further. And this is true for atherosclerotic disease, myocardial infarction, stroke, but it's also true for non-atherosclerotic disease, which becomes incredibly common at severe CKD stages. You may have known since the first day you walked onto wards as cardiologists that you need to think about pharmacokinetics of drugs. You need to think about bleeding tendency and a propensity for hyperkalemia and for acute kidney injury. But you may not know quite how close the bidirectional relationship is. Here it is quantified. Within the 6 months after an instant heart failure admission, there is a 30-fold increased risk of developing kidney failure. That risk remains high and persists for at least 3 years. And in the absence of heart failure, if you have an instant myocardial infarction or stroke, then the risk is 2 to 3-fold increased as well. So there's described a vicious cycle of CKD and cardiovascular disease. And really the trigger for brand new guidelines is that there is now actionable evidence. We all need to be taking a role in this actionable evidence. And this is from large trials testing the SGLT2 inhibitors, 3 large trials, semaglutide, a GLP-1 receptor agonist, 1 large trial, and 2 large trials in diabetic kidney disease of the non-steroidal mineralocorticoid receptor antagonist finerenone. But there's actually an urgency to act, not just a need to act. And these data bring this into close focus. So in 2016, chronic kidney disease as an underlying cause of death was in the top 16 killers globally, but it's projected in the next 2 to 3 decades to move into the top 5 alongside ischemic heart disease and cerebrovascular disease, COPD, and Alzheimer's. And by current definitions, we estimate around 800 million adults globally have CKD, which means there are 100 million people, particularly adults, we have to consider within Europe. The World Health Organization has taken notice. In 2025, they issued a directive in order to improve kidney health globally in order to reduce the global burden of non-communicable diseases, by which we mean mainly cardiovascular disease. And we need all those that care for patients across Europe to identify these 100 million, to consider active identification and then active initiation of what are cost-effective interventions which will help reduce the global burden of both cardiovascular disease and chronic kidney disease. And with those really motivating statistics behind us, the task force put together 5 aims. Some were nephrological, really early diagnosis of CKD and appropriate use of kidney failure modifying therapy. But really also early diagnosis of cardiovascular disease in patients who've got chronic kidney disease, aiming to prevent it, but also providing an important reference document for cardiology on how to modify treatments in the context of chronic kidney disease. And we really hope that this stands as an important reference document, and Kevin will talk to those in the second half of this talk. We also want to preserve kidney function, and we need to consider how that is done when medical therapies and procedures which could be nephrotoxic are introduced. But most importantly, we have a high-risk, vulnerable and complex group of patients who need to have no delay in their treatment. Our patients have reminded us that it is not only communication between specialties, but particularly communication with them. In mild to moderate disease, CKD is asymptomatic, and they need to be reminded that they are at high risk in order for them to be adherent to the treatments which are recommended by us as clinicians. So here is the guidelines acronym. It's STAMP on CKD. Let's eradicate CKD. And STAMP stands for screen, T for triage, A for address risk, M for modify approaches, and P for plan healthcare services. And up to section 7 of the guideline covers the S, T, and the A, which I'll introduce for you in next few slides. But then there is a substantial section 6 to 13, which covers modifying approaches to cardiovascular disease management. And then there's a section on planning healthcare services for efficient treatment. So here is the central illustration. We've turned it onto a landscape format for this slide. This is just selecting out some of the recommendations under each of the S, T, A, M, and P. It's going to be a practical guideline that you can use on the wards. There is incredible detail, so please do attend some of the sessions over the next 2 days where we can go into every aspect. So who should you be screening for CKD? Well, the answer is we think that anyone with instant cardiovascular disease should be screened. You'll be surprised how many patients will have disease. What should you be screening with? Well, I suspect all of you are already measuring a serum creatinine and thinking about GFR, but we want you to bring urine into the cardiology clinics. Urine needs to be sent to the laboratory, not just dipsticked, and you need to measure albumin and creatinine. This is a spot test, a ratio of 2 concentrations, reported in either milligrams per millimole or milligrams per gram. If it is a new identification, you do need to consider chronicity. Obviously, a new, sudden and unexpected decrease in eGFR needs consideration of acute kidney injury. But when chronic kidney disease is confirmed, we recommend all patients have basic risk stratification. Now, you can hear tomorrow about different equations which we can use to calculate an individual's absolute risk of kidney failure and cardiovascular diseases. But a very simple triage system, which is now well established and used, and I hope you've seen before, is the KDIGO heat map, with green being normal risk, a general population, yellow being moderate risk, orange being high risk, and red being very high risk. This is particularly striking for kidney failure risk, but it also is mirrored across all of the cardiovascular diseases which are associated with chronic kidney disease. And the G and the A criteria, G is GFR, below 60 is a category 3, and G5 is referred to as kidney failure. So kidney failure is the severest form of chronic kidney disease. It's where symptoms develop and when we start to consider whether dialysis is required. And the A1 to A3 designation simply replaces the old normo, micro, and macro albuminuria, which you may have learnt when you were at medical school. The ratios, the numbers you need to remember simply for the A2 thresholds is 3 and 30 milligrams per millimole, times that by 10 for milligrams per gram. But what is most important is the A. We didn't say this was action, but I think it should be A for action. It's address risk. Don't leave this to someone else. Everyone with CKD deserves to be initiated on treatment as soon as it is identified. All you need to know is their diabetes status, their eGFR, and their level of urinary albumin. We do recommend, obviously, the general recommendations for risk, so smoking cessation, weight loss. We won't cover statin-based regimens, but we will do tomorrow. But these new therapies, in particular, are indicated once you have people on an ACE or an ARB, which are widely recommended to slow progression, treat blood pressure, and also reduce cardiovascular risk. You'll be using SGLT2 inhibitors widely. You're familiar as a community, and they should be used widely in people with or without diabetes. And in the context of persistent albuminuria and diabetic kidney disease, we would encourage you to consider the add-on therapies of finerenone and semaglutide. Full details will be available tomorrow, But for 1A rigorous evidence-based guidelines, we do need to have the EGFR and the UACR criteria based on the eligibility of trials considered. We've put this together on an algorithm, and I'll explain this in more detail. You'll notice that we can't, because we don't have the evidence, recommend optimal ordering, but you should be prioritizing the initiation, titration, and use of these treatments in combination urgently in those people at highest risk. So you need to know the urine albumin levels as well as the EGFR in order to triage who should be seen recurrently to establish full treatment, as well as identifying which treatments to provide people with. This might sound obvious and may go without saying, but these drugs that we've been describing modify risk. You need to be modifying risk. They lower blood pressure and they improve glycemic control, but you should establish people on these proven therapies which are cost effective before then polishing glycemic control and blood pressure, etc. Okay, I appreciate you spending 10 minutes listening to a nephrologist. I'm now going to hand you over to Kevin Damman to discuss how the management of chronic kidney disease and cardiovascular disease should be considered and side by side.
Well, that's unusual. Thank you, Will. We move from the prevention and treatment of cardiovascular disease in patients with chronic kidney disease to the treatment and prevention of events in patients with cardiovascular disease who also have chronic kidney disease. And we'll touch upon a few recommendations along the way for different diseases, and we start off with heart failure. You just had a whole new heart failure guideline, and our recommendation will be mostly aligned with these new guidelines. And heart failure, of course, in the light of cardio-renal interaction, is an important condition, as the pathophysiology is closely linked to heart-kidney interaction, but also drugs, like you just heard. Foundational medical therapies work mostly through intrarenal mechanisms, and they impact the changes in kidney function over time. So as you just heard, that for most patients who have heart failure with chronic kidney disease, there's an indication for loop diuretic therapy if the patient is congested. And in all patients with heart failure and chronic kidney disease where the EGFR is above 20, there's an indication for SGLT2 inhibitors as foundational medical treatment. When we go to heart failure with reduced ejection fraction, there's an indication for RAS inhibitors, class 1 recommendation for beta blockers. And this is slightly different from the heart failure guidelines. We split the recommendation for the type of MRA based on ejection fraction, slightly, and I'll show this. So there is an indication, a recommendation for steroidal MRA if ejection fraction is below 40. And that recommendation is still there with a 2A recommendation if ejection fraction is equal to or above 40. And in this case, you can also use a non-steroidal MRA. And the reason for this slight diversion from the heart failure guideline is that there is meta-analytic evidence for heterogeneity based on the treatment effect of these drugs, based on baseline EGFR and ejection fraction. Overall, it's important to realize that for foundational medical treatments or additional medical treatments in heart failure, there is not much evidence in patients with EGFR below 30, of course with the exception of SGLT2 inhibitors. When we move to decompensated heart failure, it's important that you realize that these patients are the highest risk in heart failure and they are diuretic resistant. And therefore, you need to adequately dose these patients. That means higher doses of loop diuretics if there is baseline chronic kidney disease. We want you to start SGLT2 inhibitors as early as possible. You've just heard it in heart failure guidelines as well. And because of this diuretic resistance, consider the upfront combinational diuretic therapy such as acetazolamide and thiazides. And when you start these loop diuretics, assess diuretic response and adjust diuretic dosing accordingly, especially in these high-risk patients, to improve short-term outcomes. Now we move from heart failure to atherosclerotic cardiovascular disease. In chronic coronary syndromes, there is an indication for statin-based lipid lowering and also antiplatelet therapy, despite the higher bleeding risk these patients with chronic kidney disease have. And this is also a reason for the recommendation on dual antiplatelet duration, which may be abbreviated after elective PCI. Now in acute coronary syndromes, and this is really important, you need to avoid delays in the immediate and early invasive strategy. And this is something that comes back for many of our acute treatments in patients with chronic kidney disease. The efficacy of these potential life-saving therapies is similar in patients with chronic kidney disease and those without. And similar to the chronic coronary syndromes, also in patients with acute coronary syndromes, consider dual antiplatelet therapy to be de-escalated or abbreviated. Now, the high bleeding risk for patients with chronic kidney disease will also make you perhaps change your therapy based for anticoagulation in patients with thromboembolism and atrial fibrillation. And as you can see in this graph, if eGFR is slightly reduced, 30 to 60, there's a preference for DOACs over vitamin K antagonists. When eGFR is slightly lower than that, there's a preference for factor Xa inhibitors, and below that, so eGFR below 15 or patient on dialysis, the decision to anticoagulate should be highly individualized, as should be the type of anticoagulation used. And there's a slight preference for either low-dose factor Xa inhibitor or vitamin K antagonists. Now, patients with chronic kidney disease will often undergo diagnostic and perhaps therapeutic procedures where contrast is used. And as such, these patients will be at a higher risk of contrast-induced acute kidney injury. Again, it is important to realize that you should avoid delaying procedures and interventions to ensure timely diagnosis and treatment in these patients. Permanent harm associated with contrast-induced acute kidney injury is rare and nearly always outweighed by the benefit of doing these diagnostic and therapeutic procedures. When eGFR is below 30, it's recommended to use specific contrast media and contrast-sparing protocols, and you may consider peri-procedural intravenous hydration in these patients. Now, Will already alluded to how we see that the patient and all our multidisciplinary healthcare professionals will integrate these recommendations, and we feel that these recommendations and decision on treatment should be communicated in an open and clear way to our patients, their caregivers, and also other healthcare professionals. And as you read these guidelines, you will see that you need to highly individualize our recommendation for the specific patient sitting in front of you. So these are the key messages of this brand new ESC guideline on cardiovascular disease and chronic kidney disease. Screen all patients with cardiovascular disease for chronic kidney disease using eGFR based on serum creatinine and spot urine albumin. All clinicians should engage in managing risk of cardiovascular disease and kidney failure using ACE inhibitors, ARB, statin-based therapies, SGLT2 inhibitors in the majority of these patients. And when there's also diabetic kidney disease and albuminuria, use GLP-1 receptor agonists and non-steroidal MRAs. And be aware when chronic kidney disease necessitates changes to standard approaches. And I've just shown you examples of foundational medical treatment and depending on baseline eGFR and heart failure and the higher doses of loop diuretics needed in the patient with decompensated heart failure. Patients with coronary syndromes and chronic kidney disease have a high bleeding risk, and this may impact the duration of dual antiplatelet therapy. DOACs are preferred over vitamin K antagonists, and when eGFR is lower, factor Xa inhibitors are preferred. Permanent harm directly from contrast-induced acute kidney injury is relatively rare and nearly always outweighed by the benefits of imaging and therapeutic interventions. Plan health services for the complexity of chronic kidney disease. And from a patient perspective, communication and education about chronic kidney disease is key, and minimize delays to treatment to cardiovascular disease. We hope you will join us tomorrow when we dive deeper into the details of our recommendations. And you can find these guidelines, of course, now in the ESC Pocket Guidelines app. And importantly, there's also a patient version of this guideline where you can actually point your patients to these guidelines and tell them what they need to know about chronic kidney disease. In November, we have 2 webinars, and we'll hope you join us online and ask critical questions. And with that, I just want to recognize everybody who helped in the development of these new guidelines, specifically nephrologists in our task force from the European Renal Association, our cardiologists from the ESC, of course, Will for co-chairing and being here on stage as a nephrologist, but also the task force coordinators, Josine, Caitlin, our methodologists. This has been a true effort for the whole team, and with the new level of evidence, Bruno, Davide, and Marietta had a big piece of the puzzle, I would say, for this recommendation, for this guideline. and of course our patient representative Liz. Thank you for your much needed reflection. Thank you.